Welcome to this video on extracapsular coblation tonsillectomy. We begin by grasping the tonsil and medializing this in order to demonstrate the most lateral limit of the tonsil. I begin my dissection as medial as possible to preserve as much of the anterior pillar as possible. I use the coblator to separate the overlying tissue and to get immediately onto the correct plane. This dissection is continued toward the superior pole. In children, I prefer to use lower power settings, often using 5 watts for the coblator. This is in order to reduce the thermal injury and thus pain associated with the procedure. In addition, I use the coblation function sparingly. The wand of the coblator is shaped to provide a broad surface area at the tip. This can be used to gently dissect the capsule away from the underlying fascia, with the coblation function reserved for thicker bands which are not readily dissected in this way. I also prefer to use the operating microscope when performing this surgery. The improved magnification allows you to identify and cauterize blood vessels before they are dissected, reducing intraoperative blood loss. Secondly, the microscope is far more ergonomic than using a heavy headlight and/or loops, and allow the surgeon to remain in a head neutral position throughout the operation. It's important to remain within the correct plane in order to allow the tonsil to be dissected with minimal effort. Sometimes, however, the plane may be obliterated by scar tissue from previous recurrent tonsillitis or previous peritonsillar abscesses. Once the superior pole has been released, the tonsil is re-grasped at the superior pole, with traction applied to the tonsil medially and inferiorly. This helps to demonstrate the correct plane of dissection. As the wand of the coblator is consistently directed towards the capsule of the tonsil, this helps to ensure that the surgeon remains within the correct plane, while minimizing the thermal action on the underlying muscular fibers. The dissection continues all the way to the inferior pole, which is dissected circumferentially until the tonsil is removed in its entirety. Once removed, the bed of the tonsil is inspected for any actively bleeding vessels, which can be arrested with targeted cautery. Once I am satisfied that hemostasis has been achieved, I will then move to the contralateral tonsil to repeat the process once again. As before, the hand which is grasping the tonsil often plays as much of an active role in dissection as the hand using the coblator. This hand should consistently apply traction in a vector that opens up the plane, facilitating dissection by the coblator. Often the optimal vector will require the tonsil to be re-grasped in a different position, and so the surgeon should develop an understanding of how to use the non-coblating hand effectively. Although the extracapsular approach carries a slightly higher risk of secondary hemorrhage and can be associated with slightly higher post-operative pain scores, in patients with recurrent tonsillitis, the risk of tonsillar regrowth with intracapsular approaches and the potential for further tonsillitis leads me to favour an extracapsular approach for this cohort of patients. In addition, the extracapsular approach can be performed more quickly and be associated with very minimal intraoperative blood loss, and is less painful than dissection with conventional bipolar diathermy. The advantage of the microscope in identifying blood vessels is again demonstrated here, where a small blood vessel is easily seen and so can be cauterized before any bleeding occurs. As before, the dissection continues towards the inferior pole until the entire tonsil has been dissected. Care must be taken not to transect the tonsil and to ensure that the capsule has been dissected around circumferentially. Particularly when approaching the inferior pole, the position of the microscope may need to be adjusted in order to optimize the view. This is one slight disadvantage of using the microscope, as it requires the surgeon to be cognizant about optimizing their view and have a low threshold to adjust the view as necessary. Whereas with a headlight, the surgeon can very easily shift their perspective intuitively and without interrupting dissection. Once both tonsils have been removed, I like to inspect the fossae using a dental mirror. This allows the entire fossa to be inspected systematically with no blind spots. Judicious and targeted cautery is applied to any bleeding areas or any superficially visible blood vessels which may not be actively bleeding but carry a risk of secondary hemorrhage. The surgical bed on both sides are examined systematically, and once I am satisfied that hemostasis has been achieved, the gag is relaxed for 90 seconds in order to allow for any other blood vessels to reveal any further hemorrhage. I hope you enjoyed this video. Please consider liking and subscribing for further content.